Καλησπέρα σε όλους. Αξιότιμοι συνάδελφοι, εκλεκτοί συνεργάτες, αγαπητοί φοιτητές. Είναι πραγματικά ανίποτη χαρά και η τιμή μου να προεδρεύω σήμερα στο πρώτο διαδικτυακό μάθημα του ελληνικού δικτύου Διαβήτη στην πρωτοβάθμια φροντίδα υγείας, εν συντομία αποκαλούμενο ΕΔΥΠΦΗ. Για όσοι δεν με γνωρίζουν, λέγομαι Φίλιππος Ριχάρδος Δωμάγερ. Είμαι γενικός οικογενειακός γιατρός και βιοστατιστικός, μέλος ΣΕΠ του Ελληνικού Ανοιχτού Πανεπιστημίου, εθνικός εκπρόσωπος της Ελλάδας στο EGPRN, που είναι το Ευρωπαϊκό Δίκτυο Έρευνας για τη Γενική Ιατρική. Και έχω επίσης την τιμή να είμαι ταμείας και μέλος του Primary Care Diabetes Europe, της Ευρωπαϊκής Επιστημονικής Εταιρείας για τον Διαβήτη στην πρωτοβάθμια φροντίδα υγείας, τον πρόεδρο της οποίας, καθηγητή Xavier Cos, απόψε φιλοξενούμε. Και τέλος, είμαι και πρόεδρος του ΕΔΥΠΦΗ. Θα ήθελα καταρχήν να συστήσω τους συμμετέχοντες στο πάνελ. Έχουμε καταρχήν τον καθηγητή, τον κύριο Κος, ο οποίος είναι αναπληρωτής καθηγητής ιατρικής στο Αυτόνομο Πανεπιστήμιο Βαρκελόνης, γενικός οικογενειακός γιατρός, υπεύθυνος καινοτομίας στο Ινστιτούτ Καταλά ντε λα Σαλούτ στη Βαρκελόνη. Είναι, όπως σας είπα, πρόεδρος του Primary Care Diabetes Europe και συγκαταλέγεται μεταξύ των πλέον αναγνωρισμένων επιστημόνων και ακαδημαϊκών στο σαχαρό διαβήτη στην πρωτοβάθμια φροντίδα υγείας, έχοντας διεθνή απήχηση ως προς το έργο του. Επίσης, έχω τη χαρά να φιλοξενώ μαζί μου στο πάνελ τον κύριο Μάρκ Παπαθανασίου, ο οποίος είναι σε όλους σας γνωστός, πιστεύω, είναι γενικός οικογενειακός γιατρός, ασκεί ιδιωτικά την πρωτοβάθμια φροντίδα υγείας και ταυτόχρονα έχει σημαντικό κλινικό έργο στο Ηνωμένο Βασίλειο τα προηγούμενα χρόνια. Για όσους δεν μας γνωρίζουν πολύ καλά, επιτρέψτε μου παρακαλώ να πω δύο λόγια για το τι είναι το ΕΔΥΠΦΗ και καταρχήν τι επιστημονικό και πρακτικό κενό φιλοδοξεί προς το παρόν να καλύψει. Όπως γνωρίζετε, ο σαχαρώδης διαβήτης τύπου 2 εν προκειμένου, είναι υπεύθυνος για πολλά εκατομμύρια θανάτων. Μόνο το 2015 είχαμε 5 εκατομμύρια θανάτους παγκοσμίως. Και η συνολική του νοσηρότητα και θνησιμότητα είναι υψηλότατη, αθρηστικά υψηλότερη από ότι η νόσος HIV, η φυματίωση και η ιερονοσία. Ταυτόχρονα, ο σαχαρώδης διαβήτης έχει πολλαπλές συνοσηρότητες. Και έτσι υπάρχει μια σημαντική ανάγκη για να παρακολουθούμε τακτικά τους αρρώστους μας και να τους παρακολουθούμε με συγκεκριμένους δείκτες ποιότητας. Με συγκεκριμένες, λοιπόν, διαδικασίες οι οποίες εξασφαλίζουν στον ασθενή μας ότι θα λαμβάνει την καλύτερη δυνατή φροντίδα. Και νομίζω, αγαπητοί συνάδελφοι, ότι ο ρόλος αυτός ανήκει πραγματικά σε εμάς, τους γιατρούς της πρωτοβάθμιας φροντίδας υγείας και σε όλους τους επαγγελματίες υγείας που απαρτίζουν την ελληνική πρωτοβάθμια φροντίδα υγείας, καθότι έχουμε αποδείξει και εμείς με δικές μας μελέτες ότι η συντριπτική πλειοψηφία των ασθενών, το 84-88% των Ελλήνων ασθενών, πρωτοδιαγνώσκονται αλλά και παρακολουθούνται από γιατρό της πρωτοβάθμιας φροντίδας υγείας. Άρα, για να ισχυριστεί κανείς ότι ο Έλληνας οικογενειακός γιατρός και ο γιατρός πρωτοβάθμιας φροντίδας υγείας πράγματι επιτελεί το ρόλο που του αναλογεί, θα περιμέναμε να έχουμε κατευθυντήριες οδηγίες προσαρμοσμένες στην ελληνική πρωτοβάθμια φροντίδα υγείας και θα περιμέναμε και να έχουμε και δείκτες ποιότητας για τη διαχείριση των διαβητικών ασθενών. Και θα περιμένουμε επίσης να έχουμε και πολύ καλά εκπαιδευμένους τους γιατρούς και τους λοιπούς επαγγελματίες υγείας πρωτοβάθμιας. Έτσι, έχουμε ήδη κάποιες κατευθυντήριες οδηγίες στην καθηγητή Ιανουαρίου το 2015, οι οποίες όμως δεν είναι επικαιροποιημένες. Ενώ ως προς τα υπόλοιπα, το κατά πόσον έχουμε δείκτες ποιότητας, κατά πόσον έχουμε προσκόλληση των γιατρών στις κατευθυντήριες οδηγίες αυτές που έχουμε, όλα αυτά είναι μεγάλα κενά. Και όλα αυτά, βέβαια, έχουν σαν αποτέλεσμα να έχουμε σημαντικά προβλήματα, σημαντικές ελλείψεις στη φροντίδα των διαβητικών ασθενών. Εδώ, λοιπόν, έρχεται ο ρόλος ο δικός μας. Και επειδή δεν ανακαλύψαμε εμείς τον τροχό, παραδειγματιστήκαμε από το τι γίνεται σε άλλες χώρες και επιτρέψαμε να πάρω το παράδειγμα της Ισπανίας. Και το παίρνω αυτό διότι η Ισπανία είναι μια χώρα μεσογειακή όπως η Ελλάδα, η οποία μοιράζεται με την Ελλάδα πολλά κλινικά και γεωγραφικά χαρακτηριστικά. Ο πληθυσμός έχει πολλές λοιπόν ομοιότητες. Και τι κάνουν στην Ισπανία? Εδώ και 20 χρόνια έχουν ιδρύσει το δίκτυο Redgetaps, που είναι ένα ισπανικό δίκτυο ιατρών πρωτοβάθμιας φροντίδας υγείας, που ξεκίνησε με μικρά βήματα, όπως καλή ώρα ξεκινάμε και εμείς τώρα. Ήταν λοιπόν κλινικές μονάδες, οι οποίες δικτυωθήκαν μεταξύ τους και είχαν σαν σκοπό να φτιάξουν κάποιους ποιοτικούς δείκτες διαχείρισης των ασθενών στην πρωτοβάθμια. Να στήσουν κάποια εκπαιδευτικά events για τους γιατρούς της πρωτοβάθμιας. Εν τέλει όλα αυτά να μεταφραστούν και σε ερευνητικό έργο. Και αυτό που καταφέρανε, και είναι νομίζω πολύ ενδιαφέρον, με όλη αυτή την διαδρομή την 20η, είναι να έχουν ένα τεράστιο δίκτυο απλωμένο σε όλη την Ισπανία, το οποίο είναι αναγνωρίσιμο όχι μεταξύ των επαγγελματών υγείας μόνο, αλλά και μεταξύ των ασθενών. Και όπως μου έχουν εκμυστηρευτεί συνάδελφοί μου από την Ισπανία, στους ασθενείς είναι αναγνωρίσιμο το σήμα αυτό του Redgetaps και οι ασθενείς προτιμάνε να επισκέφτονται τέτοιου είδους ιατρία, διότι γνωρίζουν ότι οι επαγγελματίες υγείας που ασκούν την ιατρική εκεί έχουν κάποιο ελάχιστο επίπεδο εκπαίδευση στο σαχαρό διαβήτη και ακολουθούν κάποιες ποιοτικές προδιαγραφές στη διαχείρισή του. Αυτός λοιπόν είναι και ίσως ο πιο φιλόδοξος, ο απότερος στόχος μας για το ελληνικό δίκτυο διαβήτη. Είναι λοιπόν ένα σωματείο, μη κερδοσκοπικό προφανώς, το οποίο έχει σαν σκοπό την προώθηση της μελέτης της συνεχιζόμενης επιστημονικής κατάρτισης και έρευνας στο τομέα της σαχαρού διαβήτη. Με συνεργασία μεταξύ όλων των εμπλεκόμενων στην πρωτοβάθμια φροντίδα υγείας, αλλά και ανώτερης φροντίδας υγείας, καθώς επίσης και πανεπιστημιακών κλινικών. Το Διοικητικό Συμβούλιο του δικτύου μας αποτελούν 7 εκλεγμένα μέλη, πολύ γνωστά νομίζω στην ελληνική γενική ιατρική, ο κύριος Αστηριάδης, ο κύριος Γκισλής, ο κύριος Κουναλάκης, ο κύριος Καλαϊτζόγλου, ο κύριος Μπουρδάκης και ο κύριος Τσακουντάκης. Αντιπροσωπεύουν όλο το φάσμα της γενικής ιατρικής, όλη την, νομίζω, την γεωγραφική επικράτεια της Ελλάδος. Έχουν πολύ αξιόλογο επιστημονικό και εκπαιδευτικό έργο και ήδη στα πρώτα βήματα του δικτύου έχουν σταθεί πραγματικά αρρωγοί στην προσπάθειά μας. Η ψυχή όμως και η δύναμη του δικτύου νομίζω ότι είναι τα μέλη του και όλοι εσείς που είστε απόψε εδώ, και σας ευχαριστώ και πάλι, έχοντας αποφασίσει να αφιερώσετε λίγο από τον πολύτιμο χρόνο σας, και ξέρουμε όλοι πόσο πολύτιμος είναι αυτός, ειδικά στις μέρες μας, για να μας γνωρίσετε και κυρίως για να ακούσετε τι έχει να μας πει ο καθηγητής Κος. Ο καθηγητής Κος, ο οποίος είναι ο πρόεδρος του Ευρωπαϊκού Δικτύου για τον Διαβήτη στην Πρωτοβάθμια Φροντίδα Υγείας και τον οποίον θα αφήσω τον ίδιο να μας το παρουσιάσει καλύτερα. Έτσι λοιπόν, κλείνοντας τη δική μου εισήγηση, η σκοπή του δικτύου μας είναι η ερευνητική καταρχήν, να φτιάξουμε αυτούς τους δείκτες ποιότητας που χρειαζόμαστε για το διαβήτη στην πρωτοβάθμια φροντίδα υγείας. Και με χαρά σας ανακοινώνω ότι ήδη έχει ολοκληρωθεί το πρώτο Delphi Panel εμπειρογνωμόνων, στους οποίους είχαν τη χαρά να συμμετέχουν 4 από τα μέλη του δικτύου μας, η κυρία Δράκου, η κυρία Κατσούρη, ο κύριος Μπουρδάκης και ο κύριος Φραγκούλης, μεταξύ Ευρωπαίων εμπειρογνωμόνων, με σκοπό να καταρτήσουν δείκτες φροντίδας για το διαβήτη στην πρωτοβάθμια φροντίδα υγείας. Και οι δείκτες αυτοί τώρα θα τεσταριστούν σε περίπου 30 ιατρία πρωτοβάθμιας φροντίδας υγείας μελών του δικτύου μας. Και φυσικά όλα αυτά τα μέλη θα αναγνωριστεί το επιστημονικό τους έργο καταλήλως. Έχουμε τις εκπαιδευτικές μας δράσεις, η πρώτη εκ των οποίων είναι σήμερα, και συνεχίζουμε με άλλα μια webinars μέσα στη διάρκεια του 2022, τα οποία είναι διαθέσιμα στην ιστοσελίδα μας. Webinars τα οποία μετέχουν και μέλη του δικτύου ως εκπαιδευτές, αλλά και προσκεκριμένοι ομιλητές τόσο από την Ελλάδα όσο και από τον ευρωπαϊκό χώρο. Ταυτόχρονα σχεδιάζουμε και άλλες εκπαιδευτικές δράσεις με τη συμμετοχή των μελών του δικτύου μας σαν εκπαιδευόμενους και σαν εκπαιδευτές και εν τέλει με όλα αυτά φιλοδοξούμε να ενισχύσουμε τη φωνή των Ελλήνων γενικών γιατρών, να υποστηρίξουμε τα επαγγελματικά τους δικαιώματα, καθότι ζώντας και εργαζόμενοι σε μια χώρα όπου το σύστημα υγείας είναι βασισμένο πάνω στον ειδικό γιατρό, αυτά τα δικαιώματα θεωρώ ότι δεν είναι δεδομένα σε βάθος χρόνου. Έτσι λοιπόν σας προσκαλούμε να στρατευτείτε στη δική μας προσπάθεια, στο κομμάτι της έρευνας, στο κομμάτι της εκπαίδευσης, στο κομμάτι της επαγγελματικής αναγνώρισης, με σκοπό επιτέλους ο Διαβήτης να πάρει τη θέση που του αρμόζει στην ελληνική πρωτοβάθμια φροντίδα υγείας, θέση την οποία δικαιούται, αλλά η οποία δεν του είναι δεδομένη. Ευχαριστώντας σας λοιπόν για την προσοχή σας και πάλι για την συμμετοχή σας σήμερα, δίνω το λόγο στον καθηγητή κύριο Cos και από εδώ και πέρα συνεχίζω στα αγγλικά. Dear Professor Cos, I have just finished my introduction and I would like again to thank you very much for your participation at this first webinar of Primary Care Diabetes Greece. It is a true pleasure to have us with you, first of all because you were my inspiration for creating this network. Indeed, you have created your own networks both in Spain and in entire Europe. Secondly, because you are world-recognized expert in diabetes care in primary care. As I explained to the Greek audience, you're associate professor of medicine in Barcelona. You are the president of Primary Care Diabetes Europe, and you also have many other scientific titles that are difficult for me to repeat. Most of all, you are a very valuable friend, and I'm sure that the entire Greek audience is really looking eager to hear your speech.
Thank you very much, Philippe. For me, it's a great pleasure to be tonight with all of you. It's a big pleasure also for me to be part of this in that session. My idea today is trying to share with you some my thoughts and my experience on one domain, that is diabetes prevention. But I don't want to avoid this opportunity to congratulate you, Philippe, for your efforts to create a new wisdom in terms of managing and understanding diabetes from the primary care perspective. That happens here in early 90s, where a group of enthusiastic physicians understood at that moment that probably have to work together in terms to put all their efforts to create what it was called at that time GEDAPS. That after that, in 1998, was spread from Barcelona to the rest of Spain, creating the GEDAPS network, Bread GEDAPS. So you already explained to your colleagues that you would like to start with this primary care diabetes Greece. And I, from Spain and from Europe, we would like to try to support you as much as possible and to collaborate together with you in terms to make your group stronger and visible and successful in the future. So congratulations. And in another side, Faristo to invite me to be today with you in that session, where I'm trying to share my experience in diabetes prevention from the primary care and what are some ideas I would like to share with you with that title of evidence-based strategies for diabetes prevention. So this is my disclosures. My idea today is trying to explain part of my experience in diabetes prevention. And my experience in diabetes prevention starts in Greece many years ago, in 2005, when on the occasion of a big conference in Greece, it was the first time I've been started involving in diabetes prevention. It was in 2006. At that moment, I started working in an European project funded by the European Commission, the DG Sanco, and the Public Health Agency. But today, I would like to explain and to talk about diabetes prevention. For that, I would like to make a little introduction and then answering three questions. Why, who and how do diabetes prevention, and at the end, to give you some messages. So diabetes is a disease that has a continuity, is a continuous disease. And you see in that scheme that you can come from the normality to the pre-diabetes status to the diabetes, and on all these situations, you are also observing some metabolic disorders, and at the same time, you are starting to observe also the increase of complications, micro and macro. But we also have a status, what is the prediabetes. We have two different categories, the impaired fasting glucose or the impaired glucose tolerance, where you also in that situations that are considering as a prediabetes, also you have a higher risk of developing complications. And also it's good probably to intervene in that situation in order to prevent potential complications. In that figure here, we have what are the prediabetes diagnosis criteria. We have above the WHO or the ADA in that columns. You have the random glycemic, basal glycemic, or maybe 2 hours glycemic, or the A1C. And you probably all of you know about the different criteria. But more or less, we know that above 126 or maybe above 200 without on the 2 hours post-tolerance test is considered a threshold and a value for diagnosis. Also, the A1C has been considered by ADA and WHO as a criteria, and also we have the criteria for the random glycemic. And this is the criteria for diabetes. Considering the prediabetes, there's differences between WHO or ADA, being the ADA criteria, the American Diabetes Association ones, tighter and lower values compared with the European ones and the WHO ones. And I think this is important because probably what is considered prediabetes in the States is different, or in those countries following the ADA criteria is a little different what is considered by the WHO or the European Association of Study of Diabetes. In Spain, we are following the WHO criteria. We know that those persons that have impaired glucose tolerance, those ones that have values that are considered between 125 and we have and between 125 and 200, that it means that are persons that have these values that could be considered that what in the bottom, okay, and this is what is the persons that are between 140 to 200 at 2 hours of a test tolerance, glucose tolerance test, are considered impaired glucose tolerance individuals. Those persons are, in that study published in the Lancet in 2000, has been observed that after 10 years of that cohort follow, around 50% evolved to diabetes, keeping in the same situation 25% and 25% normal. So the normal trajectory of persons living with impaired glucose tolerance is they are going to be evolving to diabetes. So, but there's something we can do in those persons that are in prediabetes or with diabetes and they can move to normality. There are some actions we can do on that. And that we have a paper published in 2000 where we can observe that in those persons, this is a summary of clinical trials, where diet combined with exercise or many drugs, or maybe also drugs, combination of drugs, and also maybe also drugs for obesity or drugs for hypertension, observe that in some of the individuals participating in that clinical trials observe impact on diabetes prevention. So it seems that there are many actions that could have benefits in terms of diabetes prevention. But probably from the primary care, probably what it have more sense, we are doing some actions in a pre-diabetes status, pre-diabetes is not a disease, and probably that what it seems that have more sense is what could be the impact of diet and exercise on them. And that is the area I want to focus. And why? We know there are some studies, and here we have in that figure the acronyms of that studies: the Indian Diabetes Prevention Study Program, the Dachshund Study, the Malmo Study in Sweden, Diabetes Prevention Study in Finland, Diabetes Prevention Program in US, and the Kosawa Study. Both of them, and you can observe here, the reduction in the risk of diabetes on the intervention arm with diet and physical activity. And we focus our attention in the DPS. You observe that those individuals that participate in that trial, clinical trial, for 4 years, they observe a reduction of 58, considering a number needed to treat of 5.2 individuals to avoid one case of progressing to diabetes. So it seems that it has sense to have actions, and that results I just present to you are more important than those ones observed with drugs. So the action with diet and physical activity is even greater, even higher than that one we can achieve with medications. So who could be the individuals that probably we have to consider to invite to that activities, to that actions? For that reason, also, we have to invite everybody for doing diabetes prevention. What could be a good system to identify in our clinics who could be good candidates, ideal candidates to perform that actions that I just showed you that could be providing benefits? For that reasons, many countries develop questionnaires. On that questionnaires, there are some questions that a person can't just answer themselves. They can be done self-question, self-answer, and that is a questions like what is your weight, your gender, are you taking, how many days a week are you eating fruits, etc. We're going to see an example of the FinRisk. But many countries develop that kind of questionnaires. We have the FinRisk, is the questionnaire that was developed for the study, diabetes prevention study in Finland. We have other questionnaires. Some of them are adjustments, adaptations of the FinRisk, but other ones introduce new values, new variables. So probably the important thing is when you have a questionnaire, a scoring available, is just because you would like to identify which one are those persons with a higher risk to develop diabetes. Because identifying those individuals, you could be more accurate on the actions you're going to perform to that individuals in terms of diabetes prevention. But of course, any tool, any new survey or questionnaire requires of a calibration and validation in your population. And by fortune, in Greece, you have all exercise done already because you have a group studying and working in diabetes prevention in Greece that already validate the FinRisk questionnaire that could be used for the citizens in Greece because it's validated. Here, as an example, there are some validation studies in Spain that tries to assess if this questionnaire has also good, is working properly, is identifying properly those individuals in the Spanish validation. As I said to you before, these studies also, this FinRisk also have the validation into the Greek population. But it's important when you have already a questionnaire, if we have, okay, we have now a tool, but what happens? Is this tool used in the primary care? Is this tool accepted by the citizens? And when we do that, we question that to our colleagues, our peers, we know there are limited knowledge of the existence of these questionnaires as the field risk in Spain, because it is considered probably a little impractical to be used in the clinical practice. And also in terms of, for the citizens' perspective, there's also, they are not considered probably a questionnaires that could be interesting, because for many citizens, diabetes, they are not considered as an important disease. And probably for that reason, how you are going to manage if you have maybe some abnormal results, because where there's not really an important concern about diabetes. So for that reason, sometimes it's considered that although we have an instrument that could be good in terms to identify persons at risk, that could be intervening, could be persons with prediabetes, probably they are not really probably well known or use it in the clinical practice. So it's important to have guidelines or consensus in our countries that emphasize the importance of identifying those persons with a higher risk of diabetes and do some recommendations. And probably if we have computers and we have electronic clinical records, probably systems that alert the clinicians, the healthcare professionals, that individuals could be at higher risk of having that disease in the future, and probably it has sense to do some additional actions. What could be early actions in detecting persons with diabetes or detecting persons with higher risk? Of course, one is already mentioned, is doing fasting plasma glucose or hemoglobin A1C on those persons with a higher risk of diabetes, those that have other comorbidities as hypertension, obesity, dyslipidemia. Maybe because we have some parameters, some demographic characteristics that makes us probably those persons in that area have a higher risk of having diabetes, or maybe because we have a good questionnaire, as you have in your country, the field risk with the validation that you can be using in clinical practice, and that can be used by citizens, and maybe they can be done in the pharmacy at their homes, or maybe you have in your clinics, and you have in the waiting room, and the patient themselves can answer the questionnaire, and according to the results, they can give it to you, and you can provide some advice what to do next if they are in some scoring. So it's important that we have to use this kind of tools, and probably maybe it's important to identify that there are some situations that probably alert this, maybe makes more recommendable to use it that kind of questionnaires. For example, if you have a higher BMI, or you have some abdominal circumference above some results or threshold, or you have a past medical history of cardiovascular disease, probably it seems that have sense that you go to a kind of questionnaire like this, or maybe use it other strategies to detect prediabetes. And also because we know that those persons that have these intermediate values, and we know that for Cochrane Library reviews, that are worsening over time, and we know that. And we know that also there's a cumulative incidence of type 2 diabetes, and this is happening on those persons we have already detected with hyperglycemia, as I said you at the beginning of this presentation. We know that, and this is part of a study already published, that those persons that have previously impaired fasting glucose, impaired glucose tolerance, or both conditions, they have these increased thresholds of having risk of developing diabetes in 4 years. See that if you have a person living with both chronic conditions, having this impaired fasting glucose together with impaired glucose tolerance, they have 10 times more risk to develop diabetes in 4 years. So it's important that if we detect that categories, you can do something, because we know that acting on that categories have an impact, potential impact on delaying and preventing the disease. So, and how we are going to do that? And as I said you before, we are projecting you before data from the randomized clinical trials. And randomized clinical trials are done in a lab environment. Probably is what we are doing in the primary care in our offices. I'm visiting in my clinic today. In my office, I had almost 35 patients in my clinic. So, and it's important to know that normally we have in this amount of patients in our clinic, and we just visiting not just diabetes, we are visiting other chronic conditions. And it's important to keep clear if something that has been shown that it works in a clinical trial, it works in the real life. And this is the objective. We have to move from efficacy, from the lab situation, from RCTs to effectiveness. And that's the idea of the D-Plan study and the D-Plan CAT study, the study I want to share with you. The D-Plan CAT, the D-Plan study, it was supported by the DG SANCO. That is one of the agencies under the responsibility of the European Commission. And that was approved in 2004, and it was called the D-Plan study. As you can see in the figure, the D-Plan, it works for that acronym, but also in Athens, and the University of Athens Medical School was one of the centers. That's why you also have the FINRIS validated for the Greek citizens, and also you have these results from the study from the Greek population. This study, it was how it works. The idea was contacting subjects, calling them to answer the questionnaire, the FINRIS, and if they have the values above 14 in the score of the FINRIS, they were invited to do a OGT test, so oral glucose tolerance test, and according to the results, they were included on the study to be on what is called the D-Plan intervention. So initially, that study was considered to be done during 2 years. And it was up to the citizens to decide if they want to be doing, in what kind of intervention they want to be involved. Because it was a public health study. That was an approach that, in my opinion, is more illustrates better what could be considered in the primary care, when you are inviting citizens to do something and you are not forcing anybody to do to one strategy or to the other. That's why was one of the main conditions of the public health study promoted by the European Union. So persons detected having some alterations on the questionnaire, and they were, as I said you before, normal or IGT or IFG on the test, on the 75 oral glucose tolerant test, were invited to the D-Plan intervention. So the idea of this study is to evaluate the feasibility and effectiveness of type 2 diabetes prevention strategy in high-risk individuals for primary care using only existing resources in the public health system, following the D-Plan preventive model. And that was done in Catalonia, and we have here 2 publications on that particular. What we did in Catalonia is to screen persons in this manner from 45 to 75 years old, and we moved to population sampling or opportunistic sampling, okay? And the idea is, thanks to that sampling, okay, we involve 9 centers in Catalonia, where we invite the candidates to do the FINRIS questionnaire, as I mentioned, or maybe the oral glucose tolerance test. Those individuals have to do this test. I show you here the FINRIS that I mentioned you before is validated in Catalonia, in Spain, and also in Greece, and asks questions about the age, the body mass index, also this waist circumference and how you to measure. Also, if you're taking fruits, also how minutes you walk during a week, physical activity, etc. You eating fruits or greens, etc. And after that, you have a score. According to your score, you've been invited to do the other things. Here we have, and I see all the persons that were included on this study, on the D-Plan study, including a total of 4,104. As you see on the top, you see the Athens, and Greece was one of the countries that participate, bringing participants. When we observe here the results, you observe that those ones having values on having the results according to the high results, we can observe that those ones have higher values, as you see the systolic blood pressure, triglycerides, or body mass index. According the threshold is increasing, you are observing also you have more percentage of individuals on that categories. In the contrary, on the green box, you can if you see that the regular daily physical activity, or maybe the regular daily vegetables on fruit intake, it was considered a protective factors, and you see that they have higher percentage on those individuals that were with a lower categories on the points of the fearing risk. Here we have the prevalence of carbohydrate metabolism abnormalities by sex, and here and you see here that you can observe that when you are observing those per gender, we are observing that there's a difference across gender. But when you are under values above 15, you have an important increase that above 15, 50% of women and almost 61% of men have a risk of developing diabetes. So that was the idea of considering the threshold of 14, the value that it was considered above 14 to consider those individuals with a higher risk of diabetes. When you have over 40 points or more, you see that almost 80% have diabetes at 4 years' time. So I think it's important that these categories are showing that probably it has sense to using this kind of test to screen those individuals and probably to consider them as a higher risk and then to intervene, as I mentioned you before. In terms of diabetes, using that score, how feasible or how accurate was to detect persons with diabetes in that moment during the screening period. And you see that when you have over 20 points, almost 50% of men and women, both of them, have diabetes using that scoring. So that score also helps you to diagnose persons with diabetes as well. So as I mentioned you before, this is results that I mentioned till now from the D-Plan study, but now what happens on the intervention in the D-Plan can study? So, and it has been published in 2012 in this journal, Diabetologia. And that study, it was a cohort prospective study, including 18 primary care centers of Catalonia that in total take care of 4.5 citizens of Catalonia. The study duration, it was 4 years and involves 150 researchers, including GPs and primary care nurses. The inclusion criteria to be part of that study were to be Caucasic, knowing diabetes, having that age, being visited in the primary care, and not having liver, kidney, other blood abnormalities, or having dementia or mental disorders. So we follow, as I mentioned before, first double screening. We did the Fin risk and the OGT test. And then we also perform a questionnaire for the study and also a quality of life questionnaire. When we have persons above 14 on the questionnaire, we invite them, if they have no that value, we also ask them to do an optional OGT test, and then probably they have 3 different results: normal, prediabetes, or diabetes. And they will have the Fin risk above 14. It was recommended, the OGT test, and then also we have these 3 different results. Which ones were the persons, the participants we include in the intervention in the D-Plan-CAT study? So those ones that have prediabetes from having a Fin risk below 14, and those having prediabetes or normality above 14 as a Fin risk scoring. That individuals were invited to an intervention. What it was considered the intervention? Standard, just we talk about goals, we just do some recommendation. You are a person with a higher risk of diabetes. We provide a leaflet, but we don't do anything else. We just provide that information, nothing else. The same goals of the DPS were considered for the intensive intervention, trying to reduce the fat intake, try to increase the intake of fiber, encourage 30 minutes of moderate physical activity a day, and also try to encourage around 3% weight reduction. Also, that was done doing at the beginning when they were diagnosed of having this high-risk situation, being pre-diabetic individuals, having that activities, that education. And that was done due to 3 or 4 motivational interviews of 1 to 2 hours in group sessions or individual. And then, as a follow-up, we also did some SMS messages or telephone calls of follow-up. So we did 4 interventions around of 1.5 hours each: introduction, diet, exercise. And in case the person wasn't a smoker, we also did a tobacco cessation session as well. So you see this figure before, but it was at that time 2 years. In that case, is 4 years, as you can see here. So we extend the European protocol to additional years, is that we publish on Diabetologia. We have this, and as I said you before, we invite all the candidates to select what was the intervention they feel more comfortable, what was the intervention they want. And as you see here, there's not any difference between the 2 groups. So randomly, we don't do anything. We just invite them to go to the standard care or to intensive care as they wish. We show who could be the 2 interventions, and they decided. But we have equal distribution, and that it was good in terms to make the results comparable. So here I'm going to show you what are the impact in that 4 years intervention on high-risk individuals that consider having prediabetes at the initial stage by the Fin risk or on the OGT test. And as you see here, at the end of these 4 years, we can observe that it was a 36.5 risk reduction, and that it means this absolute difference between the 2 study groups. But if we observe in this Kaplan-Meier figure, we can observe that this is a cumulative probability of being without disease, and you see that the persons in the intensive care group, that is in orange, is those ones that have less cases of diabetes. That's why they are in the upper zone, because they are remaining diabetes free. And you see, we can compare these 2 different incidences we see that the NNT is 9.5. That it means we need to include like 9.5 individuals on the intervention to avoid and delaying one case of diabetes in 4 years. This is a figure I showed you before, is in terms, what are the categories, what are the aspects that were considered that having a more impact in terms to that individuals to show they've been evolving to a diabetes. And is the category of prediabetes that one that illustrate better that you have higher risk, considering that impaired glucose tolerance, it was a higher probability to evolve to diabetes compared with impaired fasting glucose. But if you have both categories, you consider that both categories have an additive effect, having at least 10 times more risk of evolving diabetes in that study period. When we omit the glucose categories at the beginning, for that, observing what are the risk factors for that, you are observing here that using hypertensive drugs could be a factor, but also the intensive intervention could be considered a protective mechanism on that individuals. But of course, in that figure, I want to compare the results of the clinical trial, the diabetes prevention study developed in Finland, with the deep plan CAT study, a study developed in the primary care in centers where nurses and GPs, including patients of their clinic, try to implement like 3 to 4 sessions at the beginning and doing a follow-up and observing if that intervention on high-risk individuals has an impact. And you can see here that has an impact. Of course, not the same magnitude observed on a clinical trial, but having a reduction of 36% and an NNT of 9.5 is really high, consider what we are normally doing in other chronic diseases or in other actions that have a really more high NNT values. Of course, this study also allow to create a document and also actions as the Image European project. And there are some actions that are available and can be used to your patients in your clinic. And you can download from that project, the Image European project. So, but also another important aspects to consider is because we illustrate here about the impact of a diet and also the physical activity. But also in that same approach, I try to review what is the state of the art of that. And I visit latest data from the Cochrane Library, and it shows that when you would like to perform in that systematic review on diet and physical activity, that it seems that it works. It's not just diet or physical activity alone. You need to combine both, because it's both, the combination of both diet plus physical activity, that one that reduces and delays the incidence of type 2 diabetes in IGT, impaired glucose tolerance persons and individuals. Also, it's important to know what is the long-term effectiveness of that. And it's uncertain at the moment which interventions can be key in terms of sustainability. But of course, we know that it's important to consider the adherence of lifestyle changes during the intervention could be a predicted greater reduction in risk during the follow-up. So adherence to that intervention is important and is crucial. And also the use of technologies has been demonstrating an impact in terms to patients to be more adherent to their physical activity or their diet. Also, it's important to know if these actions are cost-effective. And we developed also a study in Catalonia called the PREDICE study, where we also show that this activity of recommending these 3 hours or 4 hours intervention in that subjects we detect from the field risk or from the oral glucose tolerance test, we detect that this intervention is cost effective. So it has sense to do that in stems to avoid risk and cost. Also, that has been analyzed in 2017 by a systematic review, and also shown that diet and physical activity advice in diabetes prevention studies also is cost effective. But of course, now we have an intervention, we have a tool, the field risk, or we have other systems to detect high-risk individuals, like fasting plasma glucose, or maybe oral glucose tolerance test, or maybe A1C, as I explained at the beginning. We can identify that high-risk individuals. Also, we know that the best intervention to be performed in a higher impact in terms of diabetes prevention is the lifestyle interventions, more than the drugs, because the different medications used for diabetes prevention has a lower impact compared with the diet and exercise together. And also that interventions, and as has shown right now, also can be the randomized clinical trial results can be translated into primary care setting. And as I show you and demonstrate in Catalonia, we demonstrate that this intervention is feasible and is effective in the primary care setting. So, but what is next? The next thing is how we can translate into real environment. And this is a challenge because there are many different pillars we have to consider when we would like to introduce a primary prevention or a health promotion in the primary care. And this is a figure of a paper published in 2014, when it seems that there are different circles: intrapersonal, interpersonal, institutional factors, community factors, public policy. All of these different factors must be aligned in terms of succeeding on a strategy of implementing diabetes prevention in your country. So, but sometimes there's a big question about maybe we are over-diagnosing by a screening. So what is best? Because maybe we are doing a lot of screening, and sometimes that screening have no sense. And that is called also quaternary prevention. For that, it's important to avoid screening and treating. So screening everybody. That's why we have tools as the field risk, other questionnaires that allow us that probably there are some individuals with a higher risk that have sense to intervene and to do actions. For that reason, it's important to individualize the screening and screen the high-risk individuals because it's cost-effective. Also, the terms of adherence. It's important also that you have to be adherent to the public health policies, probably using mobile applications, as has been done also in the DPP in the US. They've been using applications on the mobile systems that have been encouraging the participants on that diabetes prevention study to be adherent. Also, the PRIDE project, creating a kind of networks that can empower the participants to be adherent to their change of behavior. And this is very important. Also, the participation in some countries of pharmacies, where pharmacies are considered also a places to provide prevention. This is really common in many European countries, but not in my country, for example. Now in the COVID situation, pharmacies are starting to be more involved, but not before. And also the community pharmacy is a very important professional that could have a big key role. And also we know now that, and this is also a part of a project of the D plan, where colleagues from Greece, Karamanakos, and also Kostas Makrilakis from Athens has been showing the impact that interventions on diabetes prevention also improve quality of life on participants that has been also doing that prevention, diabetes prevention activities. So it's important to answer why we have to do diabetes prevention, who must be the ideal candidate to do diabetes prevention, and how is the best way to do diabetes prevention. And here are my last slide and the take-home messages. If we have any questionnaire or any tool that could be helpful in our clinic, we have to use it. And FinRisk could be a practical screening tool, and you have validated for the Greek population. I also mentioned that that tool are identifying persons already with diabetes. And this is important also just for detecting high-risk individuals and also diabetic persons. It's important to follow a structured plan as a plan to implement to your persons with a higher risk of diabetes. A simple program as the D-Plan program, 4 hours, just 1 moment, has been showing benefits long-term. So it's important to incorporate that strategies because are strategies that works. And it's not just providing a paper, it's just sitting with the patient in a group basis or maybe one-to-one and explain about this, and that could have an impact long-term in terms of diabetes prevention. So thank you very much for your attention. And just before closing my presentation, I want to invite all of you to attend to our next conference, the PCD Primary Care Diabetes Conference in Barcelona between the 26th and 28th of May this year. Thank you very much for your attention.
Thank you very much, Professor Cos, for your very comprehensive lecture. I believe that all aspects of diabetes prevention have been presented very meticulously. And I would like now to invite Dr. Marek Papathanasiou for a commentary on Professor Cos' speech. Dr. Papathanasiou, please.
Hello, colleagues. Hello again, Professor Cos. Thank you again for your presence in our meeting tonight. It's a pleasure and an honor to actually make comments after your presentation, which was excellent, of course. And I think it was very practical in a way, because what you presented today is a clear plan for a general practitioner. How can he manage patients? How can he diagnose? And how can he can manage patients with prediabetes? So that's excellent presentation, because we all consider it's a very typical for us as general practitioners looking at the test to look at the glucose, the levels of glucose, it's 120, 126, the HbA1c, and but you provide us with more framework, because the find risk, as you described, actually helps us to discover which patients we should intervene, in which patients we should refer maybe for dietitian, dietary advice, and maybe in the future also about providing medication. Not all the patients are the same. That's excellent. That's the message you had is excellent. And find risk, especially as you have, it's been validated in Greece. It can be used daily by every general practitioner and other doctors. For example, if you look at the find risk, you find all the typical questions and things we have in our mind when I'm looking at the patient. So the patient probably comes with an elevated HbA1c. But if you look at the age too, of course, BMI, but other things too, like physical activity, the family history. We as general practitioners know our patients, we know their families. And we know the medication. For example, one of the things in the defined risk is the history of high blood pressure or use of medication. So we as general practitioners, we have the holistic view of our patients. And I advise my patient, I will be doing definitely more after your talk tonight, using the defined risk to help us, to guide us how to manage and what to do with a patient with prediabetes. I think it's a very, very important message you have provided us tonight. And also from the deadline, we have a clear, and from DPP, of course, we have a clear plan what to do with the patients. As you mentioned, it's both. It needs to be done. Diet, probably the technology will help us. In Greece, unfortunately, we have not a great access to dietitians in the state medical environment. But definitely we need to do more with that. We have to have more opportunity for patients to be helped with dietitians. But definitely, as general practitioners, we could advise along the dead plan schedule for weight loss. We could advise, as you mentioned, what could be the benefit of patient losing weight, and that would help our patients. We give a chat about weight loss anyway with our patients. We speak to our patients about weight loss, and based on the dead plan, we could give them some more clear aims for which we could aim, which could try to attain to get losing their weight, changing their diet. So one thing, as you mentioned, of course, and you give us a clear plan what to do is based on the dead plan intervention, losing weight, changing diet. The other thing is, of course, which we, of course, we can discuss with our patients is increase in the exercise level. Definitely, again, after your talk, we have a clear tool, a path, which we can follow with our patients. We're talking to our patients. So it's very, very important. Another thing I wanted to mention is that the thing that you discuss is very important. Based on the dead plan study, you mentioned that the number to treat is 9.5, if I'm correct. Am I correct?
Correct.
Which is a very actually good number, isn't it, Philip? If you think about statins and medication for blood pressure, they're not as effective, are they?
Correct.
And we have a clear tool which is so effective to help our patients. Just to clarify to maybe our younger colleagues, it's the number, NMT is the number of patients that need to treat to have a positive result, isn't it? And 9.5 is a great number. It's a fantastic number, isn't it?
Yeah. I think this is a good advice, because it's important to put in context, because sometimes it means, but we are using many other medications, and probably the NNT maybe is 30 or 35. There's no discussion on that. And here, due to what our intervention is diet and physical activity, it seems that it's a poor quality kind of intervention. But I mean, I'm sorry because I interrupt you.
No, please comment. If you have any comments, please do.
I think something you mentioned, I think is very interesting. I mean, we don't have also dietitians here in Spain in primary care. But something I'm doing, I mean, when you want a person to at least to detect what's going on in his life, in terms of you want to have a better identifying, or at least having a better way to understanding what's going on, I think it's important to invite the person to bring you some kind of homework for the next contact. Because, I mean, we are like in a kind of, and you know about the term, the marathon. This is not just one contact. We're just inviting for a behavioral change. And then it's important, okay, what is the baseline? How is the baseline situation? And then I ask, okay, please, can you put in a kind of not logbook with a pen, you write for breakfast, lunch, dinner, every day what you're eating. And you put me this from now in the next days, and you bring me to me as a homework. One important message: if the person came to you and bring these things to you, you can detect the person is committed to do something else. If the person don't bring anything, doctor, I forget it. Don't spend so much work, so much energy. If a person don't bring this small kind, of course, you have to ask him or her, can you please, it could be easy for you to register what you're eating, put in a kind of notebook, in a kind of a piece of papers, and bring it to me the next day. That allow me to understand how you are dealing every day. This is very simple, but provides you answers. Second, majority of our patients have mobiles. Majority. I ask, please, also as a complimentary thing, please do a photo of what you're eating. Before start eating, do a photo of your dish. That allow me to know the size of the dish, what is in the dish. And then I use that information to start talking with the patient and to start not blaming, just detecting what's going on, because what the person is doing is going to be crucial, because I'm just a person coaching him or her and their families to support in that behavioral change. So I think that there are important aspects I recommend and advise when you want to start talking about physical activity and diet. But at the same time, I think also it's important, if you have a simple program like the plan, 4 sessions at the beginning, some reminders, you can do it in group basis. I mean, you have to see how you are going to organize this in your clinic, or in your area. But the impact could be extremely high in terms of the benefits. And also you have your persons committed with a behavioral change. And this is really, really important. I'm seeing this because besides doing my clinic in primary care, I'm doing a specific diabetic clinic once a week in my center. I'm visiting all the diabetic persons, complex ones. They are referred to my clinic in my center for my colleagues, because I work in a group practice. So, and I see how important it is to dedicate time to explain about diet and also physical activity. And the other thing the majority of mobiles has is a podometer automatically. You just have to download the podometer or activate. And then also telling the patients that walking around 9,000, 10,000 foot a day, that could be, something reasonable. But I think it's important to see in what situation is the baseline, start talking, including this as a helpful tool, dialogue. Yeah.
Just one last thing. If I could ask you about your opinion, there will be a question anyway from our colleagues about the use of medication and metformin.
Yeah.
We know, of course, the best strategies is diet and of course it's exercise. They're very effective. Mm-hmm. We know also that now in the last recommendation from ADA, there is a mentioning about metformin, a level A evidence actually. Mm-hmm. I would like just your opinion about the use of metformin. What you do, what's your practice? Thank you.
I think the most important, it's important to explain to our colleagues why metformin. Because metformin in one of the studies, the DPP, Diabetes Prevention Program, it shows a benefit and a reduction of 32%. Paying attention, 32% reduction in a clinical trial, where the physical activity and diet, it was 58%. And when a real life study like the plan, it was a 36%. So even higher than a clinical trial with a medication like metformin. Of course, it seems easier to take a medication and being adherent to a medication than a behavioral change. Of course, if you try to do the first attempt and you are not reaching that thing, that could be a possibility, okay? But if I translate this into the diabetes field, not the pre-diabetes field, the diabetes field, I think there is a very important aspect to take into account, that is how we are as a healthcare professionals providing relevance and importance to the diet and the physical lifestyles in general. And my opinion, my personal opinion, is we don't feel so comfortable as a healthcare professionals prescribing diet or prescribing physical activity, because we are weak on that domain, and it's more complex. But when you have to treat a diabetic person, don't you think that if you are not considering lifestyle, there's a very important pillar of the treatment that you are neglecting? Because are you going to fight with the medications, with the insulin, with the orals, something that is not really well managed with the diet? And I think that's very important, because sometimes we are really drug-centric and not so much holistic in terms that this person is living with that condition. But when I'm talking about the I answered you already. I mean, of course, if diet and physical activity is not enough, I use metformin. It's okay, it's fine. But I take time to think about the diet and the physical activity, not just of the pre-diabetes situation. The majority of our patients are in that situation, obese, hypertensive. I mean, and this advice is a generic advice that it works for other comorbidities as like that ones. So the time you are spending working on that aspect and make the persons confident and responsible of their attitudes facing that is crucial. Because if we as a healthcare professionals are not providing enough importance to lifestyle, how we would like persons will be adherent to that kind of things. We are neglecting to talk about diet and to physical activity. Of course, we cannot say a person, you have to do exercise. No, this is not a good advice. We have to prescribe the exercise, and we have to assess how the person is, what is the exercise, the physical activity this person is doing. And I can recommend, no, if you are living in a floor apartment in a building, please stop two floors below and use the last steps to work to arrive to your home as a kind of exercise. If you go by a public transportation, stop one stop before and do the last walking. If you walk, if you like to walk, why don't you try to walk faster in terms of walk like windows viewing? No, try to walk a little faster. That is possible for you. Do you think you are capable to do that? Do you think that is something feasible? Do you think that maybe that could be improving your prediabetes? But we are just inviting them to do that, to incorporate them in that process of thinking and incorporate them on the decision where they must be the owners of this process of changing. Because normally GPs or healthcare professionals, we are many times recommending, being in a kind of paternalistic approach. But we have to try to incorporate the person in that process of changing. And then if he is responsible for, maybe that behavioral changes could be possible. And then when we talk in a dialogue, we incorporate them in the same position. I know this is difficult. Yes, it's difficult. How do you think I can help you in blah, 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 but not like this. You have to do that. is good for you. Hi, doctor, I know. And this person is not doing that because we know that is really complex to do it. So I think also it's very challenging for a healthcare professional to be familiar or to moving on in motivational interviewing. But I think in any chronic disease management as diabetes, prediabetes, heart failure, salt intake, for example, etc., it's very important how we are communicating and how we are incorporating the person in that changes.
Thank you.
Thank you very much, Professor Cos. So what is very interesting from what you said right now is that primary care physicians need more training. We need more training regarding motivational interview, regarding forming a therapeutic alliance with the patients, regarding coaching and supporting the patient in terms of moving on to diet, to moving on to exercise, instead of just prescribing medications that have a lower impact on diabetes prevention compared to diet and exercise. And what was also very interesting for me is what you mentioned, that diet and exercise alone do not show benefits in diabetes prevention in high-risk individuals, whereas their combination, that is diet and exercise together, is very, very important.
Correct.
So screening the patients with a defined risk questionnaire and having a cutoff score of, I don't know, 14 or 20, you presented us different scores. I don't know which one you believe that would be more effective.
The cutoff for prediabetes is 14. So I think it's also what it was validated for the Greek population. So I think is the appropriate one.
So if we find a score of 14 at least, we'll have to mobilize ourselves and motivate our patients for further entering in diet and exercise program and maybe further screening of diabetes. I don't know, would there be any age, a cutoff age? I mean, if the patient is very old, 80, 85 years old, is there a number or a specific number above which this kind of intervention would not be so meaningful? Do you think that there is some kind of would that depend on the health status of the patient as well?
That's a very interesting question. I mean, of course, the evidence was done here until 75, 74. But what is the main reason of detecting chronic disease as diabetes? The main reason is trying to avoid the long-term complications. If we that's why, for example, I mean, why no we are not doing diabetes prevention in 85 years old or 80? Because probably they're going to have not so much time to develop chronic complications. So probably we have to allow them to live in a good quality of life and not punish them with, detections and things. This could be quaternary prevention, and probably it's too much. It's very invasive. But I think that, like I was, for example, today, and I transfer that example of the age. I visit today a person of 87 years old, basal plus insulin regime, up and down, crazy. I mean, the values are below from 140 to 260. But that means it's okay. It's 87 years old. We don't have to be in panic, okay? So that's fine. We don't have to be so intensive with the insulin because then we can provide hypos. That is worse. So in terms of what you said, I think it's very important. We have a tool like the FinRisk that we can use it as a screening tool to our citizens without doing a sampling of blood tests. We can just assess. And I think, as I said, from your other colleague, Marek, I think it's important that previous family history is a key thing. It's very important. And also, when you have in front of you an obese, overweight person with hypertension and with family history, I mean, have a lot of numbers of the lottery. I mean, I'm probably doing a film risk, it just confirms what you are suspecting. And then, of course, the action. Have no any reason in any prevention, in any screening program to be screening and not do any action. And here the reason of doing film risk scoring on film risk, using the film risk or screening for prediabetes is because they are intervention that works. If not, it's not, I mean, any screening program have sense because you have an action, an intervention that you can deliver. So here, the lesson here, besides what's said before, we have a good tools. We have to think about there's some actions as diet and exercise that can work. Exercise don't mean go to the gym. No, it's physical activity. I mean, if a person walk 1 hour and a half a week, I mean, that is more than being sedentary. I mean, also there are studies that saying if you're standing more than sitting, that works. So, I mean, physical activity, not going to run or doing marathons, physical, not need to go to the gym. You can do things at home. Physical activity and a specific diet advice. And then considering that the losing weight is an objective with both things, physical activity plus diet. And it's the food plan, the thing. But for that exercise, you, as the hours, we must be to feel comfortable what we are advising. Because if not, they are persons in front of us, they are going to detect we are not secure what we are saying, and then our advice is going to be ruined immediately because we are recommending something where we don't know what to do, what to say next. So important to incorporate them in the process, important to share what we can do next and provide recipes, feasible recipes of next steps.
Thank you very much. I think these are very, very important points. Because we have already exceeded our time, I would like to take some questions from the audience. We have one question saying that I would like to ask you how difficult it was to create a primary care diabetes network in Spain. Mm-hmm. Did you have any difficulties and objections from diabetes specialties, i.e. endocrinologists? And if yes, how did you handle them? I think a very, very interesting question and very useful for us just now starting.
Very important. The father of the Reg apps in Spain was an endocrinologist with a spirit of primary care physician. And that was critical because that's true. Because instead of our colleagues consider us as an allies, they can consider us invaders. So it's important to detect those persons in your ecosystem that could be persons that could be good ones with a good reputation that would like to help you in your transformation. There's enough space for everybody, but you need to identify those persons. And I have that colleagues from Greece. I know Makrilakis. I've been talking sometimes with Apostolos Psapas, that probably all of you know because he's very famous endocrinologist. He's very committed with the primary care audience. So having an ambassador like this together with you, I mean, I think it will be the best business card for you to incorporate persons that could be understanding and could be committed with your message. And I think Philippe and colleagues, that's critical. It's a very important question. You now need to spread and to share your endeavor, your adventure with that kind of people, to validate, to make more known your attempt. And then I'm very happy to collaborate together with you in Greece, if possible, to make your action more strong. But I think this is a very good point. You need your lobby. You need these KOL people together with you to support you, okay? But they don't feel that you are a threat for them. You are going to be working with them because you are detecting, you are working in another portion. You are not, there's enough space for everybody.
Thank you very much. So apart from the therapeutic alliance with the patients, we also have the scientific alliance with
yes.
other specialties as well. So that's message number 2, I think, for today.
Yeah.
Another question from the audience is, did you manage to identify through your study, more specifically, what level of exercise and what diet changes qualified as intense intervention? And could you kindly reiterate those?
Okay. I mean, thank you for your question, but at the moment there's no answer for that. This under research, because all the data is recruited, but is not analyzed. We have, it would be very good to know if we have, because we already developed some questionnaires to detect on those persons that were responders. Consider responder, what it means, responder. Those ones that decrease the weight and follow that kind of diet and include more nuts and decrease more. This is questions to be answered. Now is a PhD ongoing at the moment to analyze diet factors. So that probably could be answered this year. And related to the physical activity, I don't know in how much detail that is analyzed, but I think it's a very good point. I think the idea is what is at least shown is the number or the time allocated. If you are dedicating 150 minutes, is the minutes that you're dedicating a week. But at the moment, from the deep plan CAT study, I cannot answer that question. Okay, but it's very relevant because then it will be not from the trials, it will be also from that study that has also, we have, for example, DNA samples, biomarkers, but we have esterage trees. We have to also to catch the resources to analyze that data as well.
Okay, thank you very much. I don't see any other question from the audience. So because it's already 9:30, we have exceeded our time limit, but I think it was really worth it. I would like to again thank very much Professor Cos for this great honor for us to participate in our first webinar, to inaugurate our webinar series. And we hope to have him again in the future in another lecture, and of course to collaborate with him as much as possible and to make use, let's say, of his valuable experience and expertise in diabetes. I would like to thank, and let me say that also in Greek, θα ήθελα να ευχαριστήσω πάρα πολύ όλους εσάς που αφιερώσατε μια μισή πολύτιμη ώρα από το χρόνο σας για να παραστείτε εδώ και να ακούσετε απόψε το βράδυ τη συζήτηση με τον καθηγητή κύριο Κος. Να σας θυμίσω ότι υπάρχουν και άλλα εκπαιδευτικά μαθήματα του δικτύου μας κάθε τρίτη Δευτέρα του μήνα στις 8 το βράδυ ακριβώς. Το πρόγραμμα έχει ήδη αναρτηθεί στο διαδίκτυο και μπορείτε να το δείτε. Στα επόμενα μαθήματα θα υπάρξουν και Έλληνες ομιλητές και οι ομιλίες που έρχονται θα είναι πολύ πλούσιες σε κλινικά παραδείγματα και πάρα πολύ πρακτικές για την καθημερινή κλινική πράξη. Αυτός τουλάχιστον θα είναι ο στόχος μας και θα χαρούμε πάρα πολύ να τις παρακολουθήσετε και φυσικά γιατί όχι, εάν και εσείς μπορείτε να στηρίξετε το δίκτυο γινόμενοι μέρη του, αλλά και συμμετέχοντας ενεργά, και αυτό είναι πιο σημαντικό ακόμα, στις δράσεις του, διότι το δίκτυο στην πραγματικότητα είστε όλοι εσείς. Εμείς είμαστε στο ΔΣ παροδικοί, σήμερα είμαστε, αύριο δεν θα είμαστε. Το ζήτημα είναι να μείνει κάποια παρακαταθήκη για το μέλλον και γι' αυτό πραγματικά χρειαζόμαστε τη δική σας βοήθεια. Τα μαθήματα αυτά θα είναι διαθέσιμα και στο YouTube για οποιονδήποτε έχει κάποιο τεχνικό πρόβλημα και δεν μπόρεσε να μπει ή για οποιονδήποτε θα ήθελε να ξαναδεί την παρουσίαση. Οπότε, εγγραφόμενοι στο κανάλι μας στο YouTube δωρεάν και αυτό, θα έχετε στη διάθεσή σας αυτό το εκπαιδευτικό υλικό, καθώς και πολλά άλλα. Again, I would like to thank you very much, Professor Cos. Thank you also very much, my dear doctor, colleague and friend, Papathanasiou, for your valuable comments and remarks. And if there is no other question from the audience, I would like to close this webinar and hope to see you again, all of you, next month.
Ευχαριστώ. Thank you very much and good luck in primary care diabetes Greece. All my support.
Thank you very much. Thank you.